There we go. Anyways, there you go, Devin. You're on.
Okay, perfect. Can everyone hear me and see the screen okay?
Yes, it's good.
Yeah, okay, perfect. Thank you for having me. Again, as Dr. Legare said, my name is Devin O'Brien. I'm a PGY2 with the University of Alberta at the Heart Center here in New Brunswick visiting. So today I'm going to present rescue cardiac surgery for failed TAVI and should one worry in increasingly lower risk patients. So I have no conflicts of interest. The outline, we're just going to go over 3 cases of rescue cardiac surgery at the New Brunswick Heart Center, some of the current literature and what it shows, and then conclusions of the case and what happened with them. So the 3 cases, the first case is a case of hemodynamic collapse. The second is one of ST elevations, and the third is one of a patient feeling generally unwell. So case 1 is a 69-year-old female, past medical history of hypertension, diabetes, dyslipidemia, obesity, aortic stenosis, a few other ones. And she underwent TAVI, had a well-tolerated balloon valvuloplasty, pre-deployment of her valve. It was a transfemoral TAVI with a 26 S3 valve, and following deployment of the valve, had significant post-valve deployment hemodynamic collapse. So here's a quick video following the deployment of the valve. We can see in this video, there's not too much abnormal that jumps out. But following the deployment, blood pressure dropped significantly and the patient flatlined. So what do we do after that?
So just stop there for a second, Devin. Maybe I'll give a tiny bit of perspective also on the, so for those who may wonder why a 69-year-old was having a TAVI, she was morbidly obese, so BMI of above 50 with previous chest radiation for cancer treatment. So there were a few reasons for that. And it was felt that that was a lower risk intervention for her. Perfect, I'll let you continue.
Okay. The second case, so a case of ST elevations, was a 72-year-old female, past medical history of hypertension, dyslipidemia, CHF, DVT, appendectomy, compression fractures, and aortic stenosis and varicose vein surgery. So again, she underwent well-tolerated balloon valvuloplasty pre-valve deployment, had a transfemoral TAVI with a 29mm Evolut valve, and on post-deployment echo, there was some AI seen. So it was felt that a post-valve deployment balloon dilatation would be appropriate to try and aid with this. And following the balloon dilatation, there was obstruction of the left main and severe AI. You can see here, this is the original valve that was deployed. I'll show that one more time here. And then
so
in the next clip,
just show it one more time. Just for people to note, I don't know if you see the bottom part of the skirt, the valve's not fully expanded there, and there's a little bit of AI sort of going to the side of and so hence why the thought of trying to open up the lower part of the valve so that it actually hugs more onto the annulus.
So then when we did the balloon dilatation after, you can see the balloon come up here, and I'll play it again, but if you can appreciate, the valve seems to pop up a little bit at the end there. And it was recognized after that this occurred on a PVC while pacing. And then this is following the balloon dilatation. We can see that the valves move significantly upwards, blocking coronary flow. And now we have some severe AI. Okay, so again, now we have significant ST elevations. So what do we do now? Case 3, so this is a case of a 69-year-old female, past medical history of aortic stenosis, dyslipidemia, obesity, bilateral knee arthroplasty, OA, gastric stapling, cataract removal, And the most significant factor why she underwent TAVI is due to COPD with an FEV of less than 1. So she, again, had a well-tolerated balloon valvuloplasty pre-valve deployment, had a transfemoral TAVI with 26 millimeter S3 valve, which was well-tolerated, and post-operatively had a heart rate in the 40s to 50s, but thought that we would just watch it. Up on the floor, she ended up developing AFib and eventually complete heart block with ST elevations. But prior to this was just feeling somewhat unwell, and that was the reason she was not discharged yet. So if this patient, this is a CT scan that she received on the floor post-operatively when she was feeling generally unwell. I'll show this again. So we'll go over exactly what happened after, but there's a, you can see a false lumen showing up right here.
Yeah, so you're showing that quite nicely. So if you play with one more time, the left atrium appears below the valve. So I just sort of circle the left atrium as it appears. So that's the left atrium there. And then there's another left atrium, which shouldn't be there, which clearly was a rupture posteriorly.
Okay, so again, in this case, what do we do now? So the current literature, so there's significant procedural complication rates in 1% to 2% of TAVIs. The risk factors are female sex, heart failure, PVD, and heavy calcifications. So it's imperative that a resuscitation plan and patient wishes are discussed preoperatively in the TAVI population. And as TAVI is used in younger patients that we're seeing now, resuscitation efforts will become more aggressive. So TAVR emergency decisions, things to note, as Dr. Legare was mentioning previously. So the patient on the table is not intubated. The cardiopulmonary bypass machine's in the room, but not directly at the bedside, and the lines are not up on the bed. The draping is not appropriate for sternotomy. So if that's required, the drapes need to come down and be redone. And there's no prep on the chest because we're working mostly from the groins. So the mortality, so the European registry from 2013 to 2016. So of note, this would have been when TAVI was just on the rise. And now that we've standardized procedures, our results are becoming much better. So back in 2013 to 2016, the European registry found that death mortality at 72 hours was 34.6%. It was 46% within the hospital stay and 78% at 1 year. So the causes of emergency cardiac surgery with TAVI, LV perforation accounts for 28% and annular rupture for 21%. So they're the majority of the severe complications that'll happen. The balloon expandable valves, the most likely complication for emergency cardiac surgery is annular rupture, whereas the mechanical like expanding valves would be dissection. So back to the cases for the conclusion. So case 1 was an aortic root rupture just after deployment of the valve. So the chest was opened with the knife directly to bone, sternum was sawed open, pericardium was open and blood was evacuated, and then cardiopulmonary bypass via peripheral cannulation where the venous was later transferred to central. So the TAVI valve was removed, the rupture was primarily repaired, and a new medium Percival aortic valve was inserted. And surprisingly, the patient was actually discharged on post-op day 5. So you can see how well these patients are doing at our center, even in significant circumstances. For case 2, valve migration. So this was the one where after balloon expanding, you could see the valve pop up. So peripheral cannulation for cardiopulmonary bypass was initiated. The chest was opened. Leaflets of the TAVI valve were removed and a new large Percival valve was inserted. And again, this person was discharged on postoperative day 8. So that was quite good result again. And the third case, the delayed aortic rupture. So on post-op day 5 was when the CT was done, and it was found that there was a contained rupture in the ventricle and a 2.3 centimeter tear below the annulus. So post-op day 5, they were brought back to the OR in more of a controlled setting this time. The chest was open, central cardiopulmonary bypass was initiated. The TAVI valve was removed. And then the junction between the non and right coronary cusp, there was a junction there that we found a 3 centimeter tear extending towards the LV apex. It was repaired with a pericardial patch, and a medium Percival valve was inserted in this case. And they were discharged post-operative day 14 from their initial TAVI. So just to look at outcomes of the New Brunswick Heart Center and how well we're doing here. So less than 1% of cases required emergency sternotomy, and we've had 0% mortality in hospital in the last 4 years. And just some points to wrap up. So all of this talk highlights the need for increased use of simulation at the New Brunswick Heart Center to go through these cases in a multidisciplinary way, so everyone's prepared when they actually happen. Lower risk patients will require ongoing preparedness, as negative outcomes will not be acceptable for these patients. And it underlines the need for continued appropriate selection of patients when choosing TAVI versus surgical aortic valve replacement. And that's just my contact information, references. And if anyone's interested in the references, they can scan that to get them. Once again, thank you for letting me share, and we'll take any questions if there's any questions.
Perfect, Devin. So if you can stop sharing, then we'll ask the audience if any questions or things they want to ask. It certainly highlights in my mind the sort of selection. You know, we didn't go into much detail, but we spent a lot of time at a TAVI rounds sort of judging what the risk of annular rupture might be. We are a mostly balloon expandable valve place, but there are certainly patients in whom a self-expanding valve would offer less risk of rupture and potentially would be of benefit. And these are the sort of dilemmas and things that we debate. And sometimes, you know, as you get in younger patients with bicuspid aortic valve, for example, tend to have much more calcium. These are the kinds of patients in which when we dictate, and I dictate a note saying, you know, we think the degree of calcification is too much, and a bicuspid aortic valve in a relatively young or younger person who's otherwise fit, then surgery is certainly worth it in that patient because we worry less about that. You know, regardless of us having stated that we did well in the last 3 patients that, you know, we present like this, it's still a highly morbid environment to require emergency surgery in a you know, still relatively uncontrolled environment. So a little bit of luck there, I'm sure, and preparedness together that really allows us to achieve that. But it does bring, as you suggested, the fact that we are doing lower risk patients. The expectation is for these patients to do well, and so to sort of talk about still a 1% risk of a major disaster potentially happening, even if it's a little bit less than that, these are things we need to be ready all the time to be dealing with and be able to salvage in an appropriate manner. And it's always a difficult environment to be in. Any questions from the audience otherwise?
Jeff, what are the biggest challenges in the operating room trying to perform these salvage procedures? You have AI, you have that Evolute up in the ascending, trying to get myocardial protection, clamp the aorta, get the old valve out, get cardioplegia in. How do you approach these cases?
Yeah, to be honest, I mean, the team is really helpful in many ways. You know, I end up focusing only on getting in. So the first case, for example, is, you know, when the patient flatlined, they had no blood pressure. And I opened the chest while the anesthesiologist was putting the laryngoscope in their mouth. Like, they were white as a drape, they were dead. and I focus entirely on opening the chest while I get my colleagues at the groin to put the patient on bypass for me. So that saves a tremendous amount of help for me. We'd already decided on our timeout initially what cannula size we would use, that kind of approach. And as soon as I get in the chest, once I relieve the tamponade, to be honest, is that patient regains normally some activity and some function at that time if it is a bleeding problem. The problem is they exsanguinate quite quickly, unfortunately. So you need to somehow put a finger on the hole or somehow tamponade that hole to allow you to give you time. But you're right. Everything in my brain tells me everything is wrong here. Everything is wrong here. The environment is wrong. You're not, the lighting's not right. All the instruments are not right. The position is not right. And you just have to basically tune that out and just focus on the things that you can do and as simplified as you can. And that's why in those cases, I ended up using a surgical valve that was that does not require sewing. So these are sutureless valve or the Percival. And the Percival valves are useful in this setting, I find. Because I can open the aorta a little bit higher. You are right that there are some challenges about cardioplegia protection, making sure the valve that had migrated up the aorta, the aorta I had to cut over where the valve was because the aorta felt solid from a valve there. And I had to essentially squeeze that valve and collapse it inside the aorta to be able to pull it out. So there are a few little challenges that come out. But people, you're in an emergency situation, and people are tremendously helpful at sort of allowing you to deal with the situation. And I would say personally, the biggest challenge is entirely how to learn to tune out all of the things that seem wrong, and focus only on the things I can do. And that's the biggest challenge I find. Would I change the way we approach things? I think there's certainly improvement we can make on the simulation side of things, and I've have some ideas, and hopefully in the new year we've chatted about this. We had some talks on simulation recently. There are some things that we potentially could rehearse or prepare a little bit better, but ultimately the decision making occurs quite rapidly, and all these three cases failed in different manner. The first one was obvious in the sense that they died instantly, no blood pressure and no blood flow. So that was straightforward. There's no choice. The second one, where the valve migrated, it bobbed it a little bit in the aorta for a few minutes before it started obstructing the left main. So then it became ischemic and quite hypotensive. So it became pretty obvious. The third one, to be honest, was, we obviously missed the injury at the time, and a few days later picked it up. These are always the concerning patients that, there was something that wasn't quite right because she didn't feel good. There was some rhythm problems. There were this, that, and the other. And so the index suspicion was there. That's why we kept her for several days. But here we are. So then obviously became obvious at 3-4 days. So we have a pretty low index for re-imaging these patients. They all get an echo the first or second day or just before discharge. And if there's anything abnormal, any chest discomfort, anything unusual, they get rescanned right away. So CT scan is very sensitive for pericardial effusion and very helpful to look at the root.
Great presentation. It's Ron Bourgeois just asking a question. I may have missed it during your discussion. How many times would you have had to go back to the OR? Is it all the cases you presented today, or are there other cases that if you have a good idea of how many you might have had to do?
Yeah, so since I've been here in 6 years, I've opened the chest 4 times and I've presented there 3 of them. The fourth one was just a wire rupture, so it was actually quite easy. It was as Devin pointed out, sometimes a wire can perforate the LV, and it was relatively easy to fix once we'd opened the chest and relieved the tamponade. It was just lifting the heart, putting a stitch on the heart, and just letting the heart back down, and that was it. We didn't need to go and bypass. We didn't need open heart opening the heart itself. And so once we dealt with the tamponade, it was relatively easy to fix. It's just no way to tell at the time when the pericardial effusion develops really rapidly and they collapse. You can't tell if it's a disastrous. And I'm sure Dr. Forgay, who's on the call, has had a few experiences prior to me coming here, some of which have been disastrous in the sense of, if you exsanguinate. We got a little bit lucky on the last one with exsanguination. Once I opened the chest and the blood was let out, I was actually able to put my finger behind the root and push on that to stop bleeding. Because obviously, if you can't keep up with the amount of bleeding coming, it's a pretty hard thing to salvage.
Great, thanks.
Okay,
So
so
it's sorry, Jeff, it's
Yep.
Vernon here. So I'd just like to congratulate the surgical team. I think it's a multidisciplinary program, but without the heavy involvement of the surgeons, we'd have several mortalities in our program. I think that's a lesson that maybe we can translate across the country. Okay. Thanks, Devin. Thanks, Jeff.
yeah, I think Vern, you bring a good point. I think collaboration is really important. You know, I'm sure there are things we can will evolve over time, but you're quite right that not all programs in Canada necessarily are doing things the way we are. Perhaps we are too ready. I'm not sure. I get the sense that I'm not ready enough sometimes in that moment. But you could imagine if this were to happen and my perfusionist wasn't in the room, cannulas weren't ready, my colleagues weren't ready to cannulate the groin, you would lose minutes of time and that patient would likely not do well. And as we stated before, even if it's 1 out of 100, this is 1 out of 100 that shouldn't happen. And we wouldn't expect that in the 65 or 68 or 70-year-old patient otherwise well going for aortic stenosis. And that's why we tend to be picky, obviously, for the indications for doing surgery or intervention is, unfortunately, not everything goes as expected all the time. On that, Devin, thank you very much again for presenting on such short notice these cases and putting you on the spot for doing this today. But it's important to highlight to everybody, you know, some of the things we do. And thank you very much and have a good day, everybody.